Okay.
Okay, so Phil, for the record, I'm just gonna say that this is a follow-up on our previous meeting, and we are still consent. Is given by you to use this for the purposes that we discussed, and of course, we'll stick to the guidelines of the consent according to the IRB. So, we went through the data that we collected last time, up till now. And Dr. and Zabla, we were thinking about what would be an interesting research question that would be of interest to the org design or org research community. And so this interview will start like sort of looking at the innovation or the innovative healthcare at Tandem from that lens. And I'll tell you the research questions so that you have that in mind. So we are looking at, in the presence of competitors, how is an innovative solution or innovative organization or innovative approach to deliver service to your clients created, and then we use this strong structuration lens to look at that. So that's technical, but this is like overall umbrella. And you got the 4 questions, which are going to be the umbrella questions. But I'm going to, we're going to kick off from what you have said in your interview before, and I might use codes to remind you if you don't remember. So let's see. So basically, the context here is we have to go back before the formation of Tandem, right? There are four groups before even Life EMS joins in. These are 4 of these competing retirement communities. Correct? This is,
Yes.
I think I have it in my notes. It's what's it? Holland Homes, Clark Homes, Sunset, and Priority Health. Is that correct?
No, Priority Health is the insurance payer. So it would have been
Okay.
Clark, Holland Home, Sunset, and Porter Hills.
Porter Hills. Okay. So let's just say the 4 people came together. These are competitors. And they have their own successful PACE programs which provide them the wraparound support for members in addition to just pure healthcare, correct?
Sort of. How familiar are you with the PACE models?
I just am getting what I got from your interview. I am not.
Okay.
So
Okay.
we're gonna have to fill in the gaps for us here.
Sure. So PACE models are very restrictive. Entrance, the eligibility for a member to join a PACE program is really highly regulated. So you have to be nursing home eligible. PACE programs can only enroll a very relatively small amount of people. So today, the only PACE program that's operating in Kent County is about 350 to 400 people are in that program. One of the other partners owns a PACE in the Muskegon area in Muskegon County. There can only be 1 PACE per county, and each PACE can only hold that 300 to 400 members. So it's not like, oh, we'll just put people in our PACE program. That's if the PACE program's full, you got to find another solution. So that's although yes, they do run PACE programs, and that PACE can be an excellent option for a limited number of people. It doesn't serve the whole community in a comprehensive way.
Okay, this is great. I mean, you went right to one of the questions that I had in the list. But I want the answer to the question. I just want you to back up a little bit, and because there's a bigger question here, right? With the 4, I don't know, are they owners of this the 4 community homes or senior retirement
the presidents and CEOs of the company.
Yeah, the CEOs of companies are sitting together, and I just want to tell you whatever you can tell about the mindset at that time, which is that there is a problem that is not being addressed.
Yep. So
and that's why we want to work around the PACE program. Is that correct understanding?
Say that one more time.
So the PACE program that you described is something that does not allow them to do something, but that something comes before, right? They're trying to solve a problem here. Can you just describe that to me from their point of view? What were they facing at that point that they were trying to solve?
At the time, these 4 continuing care retirement communities were so at right before this time, the Affordable Care Act was passed into law by the Obama administration. And part of the Affordable Care Act came penalties for hospital readmission. So at the time, everybody in healthcare, hospitals, continuing care retirement communities, nursing facilities, everybody was scrambling around trying to figure out how do we cut down on hospital readmissions. So that was the big problem that everybody was kind of looking at, right? They saw this new law coming into place. They didn't know exactly how it was going to be enforced, and they were worried that financially they were going to take these huge government penalties for hospital readmissions. So without a resource, their current resources were not sufficient to handle the readmission problem. So they all came together and formed Tandem with the idea that Tandem would kind of be the readmission solution for what they were doing. Now, as time went on and everything evolved, Tandem does not really help those four continuing care retirement communities with hospital readmissions. As time went on, it evolved into something else, and they've had to kind of solve their own readmission problems, themselves without the tool us, that they built.
So I'm going to ask you to speak about this evolution process too. But I think there's a doubt in my mind right now. So the retirement communities would be penalized due to this new change in ACA, not the hospitals.
Yeah, so the hospitals would be penalized, but all these the one of the key aspects of a continuing care retirement community is they often include independent living, assisted living, and full skilled nursing. The idea is that this is the continuing part of the continuing care is you start in independent living, and then if you age or if you get sick, you could transition into skilled nursing or assisted living within the same organization. And then if you got better, you could move back to regular independent living. So independent
Okay.
living really wouldn't take many penalties, but assisted living and skilled nursing definitely would. Another aspect is, I believe, 3 of the 4 agencies also run home care agencies, and home
Okay.
care probably would be penalized by these, readmission penalties as well.
Okay. And so if you want, you can. I have more questions about it. Do you want to handle those first, or do you want to explain to me how Tandem, from being thought of as a solution to avoid the those penalties, became complete something else?
Yeah, I can answer that however you'd like me to. Do you want me to
Okay,
try to
so
tackle that
let's
one
let's
now?
address these questions first.
Okay.
So here is I'm still taking you back to those 4 people, and everything, and maybe Tandem didn't mean that at that time. For example, some of the things I got from an interviews is that okay, this is some of the things that Tandem does. I don't know if it was thought of that it would do. It keeps them out of long-term care because it keeps them in their homes, right? It keeps them out of the emergency department, which means the emergency department don't get that money. It keeps them out of the hospitals during end of life. These are things I have gleaned from your interview, right?
Yep.
So end of life situation, you rather keep them at home or in hospice rather than in the hospital, or generally out of the healthcare system by doing a lot of preventative stuff. So was all of this there on the plate, on the table at that time, or some of this kind of came in and then the community sort of adjusted, said, okay, well, this is good for the patient, so we will
Yeah,
accept it.
a lot of it was. It's kind of
Okay.
counterintuitive, and I can see where you're running into this problem
Yes.
of
So we,
a
we, we want to
company.
address that question, but how come these competitors agree to do this
Yeah, it's
despite
a
knowing all of this stuff?
it's a great question. And part of what these companies do, right, is the leaders in these companies, they all attend the same conferences. And
Mhm.
if you've attended a healthcare conference, probably in the last 10 to 15 years, everybody is talking about this giant wave of older adults that are aging and how the systems are unable to manage them. So
Mhm.
people will call it things like the silver tsunami and other things like that, that essentially what it is it's all the baby boomers who are now retiring and requiring a lot of healthcare. and our brick and mortar solutions are inadequate. So the leaders of these organizations are thinking our brick and mortar facilities that we own, they are not sufficient to care for these people. The hospitals, they're not sufficient to care for these people either. So that's kind of where they got to this home and community based thing. They kind of built it thinking our facilities are already full. We don't need to worry about getting more people into our facilities. And this problem is going to be with us for a long time. So they're not really thinking, oh, we'll just build more buildings. They were more in the mindset that some sort of home and community based offering to keep people in their homes and out of these brick and mortar buildings was going to be a good solution.
Okay. Okay. So we understand what is the structural issues they were facing, and then they said, okay, this is a solution. And if you want to go back and cover in the round of that the issues that they were facing with pace, I think you answered that quite well. But I just for the record, I just want to say, so pace was not going to solve this problem because of
Correct.
the restriction they had. One was that you could have one in every community. It was highly regulated. And what would you not have been able to do with pace that you can do now?
So in the Kent County area, we have 800 members. Pace only has 350 to 400. So volume is a big component of that.
Okay, so there's a
Um,
restriction on volume too through pace.
yeah, they if they decide they want to grow, they have to apply through CMS at the state level to try
Okay.
to get a new facility. But they also regulate it to only one PACE organization per county. So like the PACE here in Kent County is actually expanding, but they had to open up a facility in Ionia County because they weren't allowed to build another one in Kent County.
Okay.
So even if they did want to try to be the solution, they were going to be hampered by um, amazing regulations.
Okay, so I'm ready to move on to the next question. I just want to check with Dr. Zabla if he wants to ask anything and something I have might have missed.
No, it's your show, Vivek.
Okay, okay. I just want to make sure I'm not just
Yeah,
like
go ahead.
charging ahead and like okay, that's fine. So so it's clear that there's a problem and this is the solution. At some point, did anybody like think about or like have an idea about what is the impact, the economic impact of this solution on our existing company? Was there a conversation or was there an awareness or they said, well, we know this, but we are going to go ahead anyway?
Yeah, when I talked to the people that kind of formed this, including Teresa, who was involved in the very beginning, she actually was running one of the home cares for one of these agencies. So they tapped her to build this new company. They did have some of those thoughts, like how is this going to hurt our business and all the rest. One of the things that they tried to do is early on all these companies also have what's called private duty, which is personal care aides and chore workers and stuff that would go into people's homes. And early on their goal was that Tandem would enroll patients and then we would refer back to the owning agency's private duty. And if we needed a home care episode, we would feed patients into their home cares and things. So they were thinking there was possibly some revenue that would come in. But in terms of their facilities, like they're full. So they don't really have a huge need to like get more referrals for people to go live in their continuing care retirement communities.
And you did mention this in your interview, but I just now it makes making the context is making sense to me that you said that. Okay, so let's so we talked a little bit about that part of the question which says there are these people who are competitors and they have a reason to cooperate. Now I want you to talk a little bit about it's an innovative healthcare solution. So there is, I mean, I've been doing some literature survey. There is plenty of community paramedics and something called mobile integrated healthcare. And I noticed on your website as well as some documents that Teresa has put there, you're saying this is a unique combination of the two. Can you just sell me that? Give me like a good piece on that so that I can like justify this on the
Yeah.
publication.
Yep. So one of the things that's unique about our model is we're funded and we're sustainable. So if you want to look at the next closest broad community paramedic program in Michigan, we're going to go over to Ann Arbor, and there's a program over there that's been running almost as long as Tandem has. I'm very familiar with those guys. I chat with them every other week probably, and their model does not produce nearly enough revenue to support it. So what happens is those people they're entwined in the 911 system, and it's a really they haven't been able to grow their program because they don't have any funding. So there are other people out there that are doing some sustainable things, but if there's anybody out there using nurses and social workers and paramedics and medical assistants all kind of combined in a team together to do comprehensive case management, including that urgent response that our medics can bring, we can't find them.
Okay.
You mentioned mobile integrated health. I'm very involved with the National Association of Mobile Integrated Health. So I am very involved with all of the different programs that are out there in Michigan, or in the country really. And there are some really cool things going on. But we have not found anybody like us who's funded and who has as comprehensive case management as we do.
Yeah, I'm gonna have to circle back with that, maybe offline to sort of get some. Send some references by you about some surveys and some studies that have been done, because I want to make sure that sometimes things happen and they are not published,
Yeah.
and that may be what I'm missing. But what I'm seeing so far is a lot of these are being talked about, and the definition of what it exactly is a little bit murky. So sometimes they say community paramedic, but it involves social workers, involves nurses, and vice versa. So so but i've been so so the main thing that I'm getting from what you're saying is that it is funded, and it is therefore it's sustainable, and there is not this population health management. I think that's the term, managed care. That's the
Yep.
word they use, right?
Yep.
Is being done with the help of paramedics. That's what is you're occupying that space simultaneously.
Yeah. And to make it maybe a little bit more muddy for you,
Okay.
our model is a cost savings model, right? Our
Yeah.
goal is to reduce cost. There's other models out there that do things like risk adjustment. And what risk adjustment is we get in and we, find a patient, and then we make all of their diagnoses as specific as we possibly can. So what happens then is the insurance payer gets more money from CMS.
Mm.
So there's programs out there like us. There's a big one in the country called Landmark Health. And Landmark Health does do some cost savings, but primarily their value to insurance payers is that risk adjustment. So we don't do risk adjustment. We've kind of said, risk adjustment can get more money from insurers, but it doesn't actually solve any problems for patients, right? That's where
Okay.
the cost savings models have to come in.
Yeah.
So you will find
Yeah.
other entities like us, but their models might be a little bit different.
Yeah, I mean, it's too much to get into detail into this, but I can give you a rough idea that most of the studies find that any of these solution, community paramedics or this thing, reduces uh, emergency room readmissions. However, they cannot find any difference in the cost of, it actually increases visits to primary care providers. So in total, they don't find a cost saving. But this is interesting because we can put that as a differentiator.
Yeah. Did you see the study that was published on us? Did I send that over to you?
Yes,
Okay.
and I really like it because your your design is much stronger because it's a matched cohort study as opposed to before after study, which is
Right. Right.
post.
And that's where a lot of these community paramedic programs do fail. When I mentioned the one on the east side of Michigan, what they're doing is they're doing a visit, which may include interventions or not. But that's all. They're not doing any follow-up. And what we've found is when we send a medic out, that opens up a window. And then the nurses and the social workers do all the work in the next day or week. And that actually creates the hospital avoidance. If you just go out and see a patient, like even if I go and do an intervention, like give IV fluid to a dehydrated patient, all I'm doing is you know a stopgap measure. I didn't fundamentally solve anything that was causing the dehydration in the first place. So me leaving and then having the expectation that the dehydration wouldn't reappear is it doesn't work. And that's unfortunately that's what a lot of these CP programs around the country are doing.
Okay, so now we're going to start talking about the evolution of Tandem. So I wanted us to firmly set the context that these are these four riders. So now first enters Ken Morris or first enters Priority Health. Who comes into the picture first after these four people?
Ken Morris
Ken
first.
Morris. Okay, so he designs a program. That's what you said in your interview.
Yeah, he was pretty instrumental in designing it initially.
Okay, so then tell us the story. So what made them think that we need a, this is not going to work without a paramedic, and then and what happens next? I'm just walking through this timeline.
Yeah. So Ken Morris gets involved. He talks to Mark Meyer, the owner of Life EMS, and everybody at the time, this community paramedic thing was the newest, flashiest thing in that industry.
Just
So
give me a timeline, rough year. What are we talking? 2013,
yeah,
2000.
they were in. Yeah, Life EMS was involved in 2013 before we ever enrolled patients.
Okay, go ahead.
So they decided, coupled with this other company, Tandem, we think we could spin up a community paramedic program. And also, they were charging Tandem for the use of their medics. So it's not like they were just altruistically putting up, free resources for people to grab. They built out a cost structure to it, and management fees and the different services that Life EMS provided, Tandem paid for and continues to pay for.
Okay, so community paramedic was there, from what I understand, and you can correct me because mine is very recent understanding of it, was to solve two problems. One was rural health, because there were areas where healthcare was not able to reach. And I think some of them were also like it was post-op care. So these were the two primary reasons they thought that community paramedic was a solution. And there are more places where it has happened. I mean, we can circle back and match our notes on that. I think there was some in Canada, California,
Yep.
um,
Colorado
Oregon,
was Eagle
Texas.
County, Colorado was a big one.
Yeah, Colorado is a big one. Northeast, there's a lot of data on Northeast, by the way, but we can talk about that later. But so this was already there, and then this was thought of as a solution that to make this work, this new innovative idea. Let's get EMS involved, life EMS involved, and then what happens? And when does priority walk into the picture?
Yeah. So what had happened is Life EMS came in and they started working with the planning and, figuring out what was going to happen. And then we applied for Tandem. I wasn't involved with it then, but Tandem had applied for a grant to get some funding to kind of like launch. And they didn't secure that grant. So the 5 owners came together and they said, well, let's launch anyway. So they each kicked in $500,000 or something like that. And they started enrolling patients that were referred to them from, some of it was Life EMS would make referrals. Some of it was these other entities, the CCRCs would be aware of a patient and they would refer in Tandem. So we started with 15 people or something in April of 2014. We were enrolling, right, slowly. And then the chief medical officer at Priority Health, Dr. Jay Labine, was looking for a home and community-based service. And he identified Tandem as a potential, a good option to be his service. So Dr. Labine worked closely with Teresa to hammer out a contract and figure out, what are we going to do? So in, and you'll have to pull the exact dates, but I want to say it was like September,
Yeah, we can
October.
always add details later. If you're not sure about it, just say that and I'll follow up with you.
Yeah, well, you'll have to follow up on the exact date, but I believe it was September, October of 2014 that we signed a contract with Priority, and then they actually supported us very strongly financially to start by giving us, like, we would start a new team and they would give us a huge influx of cash, and then we would grow census and then start another team and they'd give us another big influx, and then as years went by, those payments decreased as we gained census.
Okay, so I may or may not feel at any point know if there is a critical decision point in the path of Tandem's history, because this feels like a critical point, not just the priority joining in, but that all these companies not getting a grant, still feeling that still this is still a worthwhile venture. Is there something changed here? Is there something you need to add, or is the same motivation forces still continuing to drive this change?
It's probably that they did so much work to build it and they just wanted to take it for a test drive.
So there
So
is a
when they,
momentum already,
yeah,
and
yep,
people are already vested in this idea, and they're saying, okay, okay,
yeah, and they had gotten stakeholders to participate in the design from all over the place. There were people from Corewell Health that were involved. There were people from Trinity that were involved. I'll still run into people and they'll be like, "Oh, what do you do?" And I'm like, "Oh, I work at Tandem." And they're like, "Oh man, I was in meetings with that like 10 years ago." And it's like, yeah, these all these people were pivotal in kind of forming the organization. And I don't think even after losing the grant, I don't think they were willing to just say, okay, well, that's it, we're done.
I think it would be nice to get some details on what who was involved in those early meetings, and if you can find it, that would be great. Otherwise, we'll see,
Yeah,
if we need to talk to her.
Teresa was there for all of it, so she would know. She would know if you wanted a list of people or titles or whatever. We could
Yeah,
probably come
more
up with
than a
some.
list of people, the forces, how were they seeing this, what was going on, and what drove their decisions. I think that's, you will see me asking those questions now, because since we have a research question, I think we are now trying to sort of, focus on that. All right. So priority joins in, and then there are still some key changes that happen in the organization, right? this is
Oh yeah,
this is a
yeah.
major one, right? Because I heard something like you having a medical director at some point. I don't know the name's not here, but he's no longer there, and there were some big management changes. So talk me through those changes in the organization.
Um, yeah. So after they had gotten going and contracts signed with Priority, and we were enrolling patients and moving through the program, um, Teresa wound up doing a big shuffle in her leadership team. Essentially, all of the leaders that she had when the program started were exited. So she needed to develop and build an entirely new leadership team. So at that time, I don't remember, did you interview Tara Wilcox?
No.
Okay. She was the first one to come on as one of the new leaders who is still here. Um, and then she
Oh,
had one
actually, is
other.
it is Tara director clinical? Is that the
Yes.
one we're talking about? Okay, I didn't know the last name. Okay, yes, we
Okay.
did interview her.
Okay. Yeah. So she was the first one that got hired in. There was another person who was doing ops. That person lasted maybe a couple of years before she decided to exit the organization. And then that's when I was hired in ops. And then it was just me and Tara for a while, for maybe a year, and then Jay Moore, the director of tech of IT, was hired. And it's really been Teresa with the three of us leading from that point on. So that leadership shuffle was kind of a big change that happened relatively early on in Tandem's history.
So, are you able to share us about the thinking behind it and how that basically changed the direction of or did it change anything about the organization, how it went through with this change?
Yeah. So to get the exact specifics, we probably have to check with Teresa.
Okay.
But the things that I've heard are, this person was undermining what Teresa was trying to do, so she'd say yes to her face and other things behind her back. So there was
Okay.
maybe some untrustworthiness going on.
So nothing strategic, I'm thinking. It's the leadership style. Okay, got it.
Well, yeah, if you talk to Teresa, I think she would say she realized that the strategy of the organization was not going to be met by the leaders she had. So she needed to find leaders that could view her strategy and execute on it.
Okay. So so these are my questions on sort of how the leaders saw the structure and the changes that they made and bring about change. I'm going to just read back a few of your quotes and see if you want to add something to it.
Okay.
And this is regarding the uniqueness of Tandem. And you have given me enough, so don't feel that you need to add anything. So first you think you address that Tandem kind of operates in the middle space of community paramedic and case management. That's yes to that. The state refers to us as the unicorn project. I'm just quoting from your because everybody had this idea, but this should be able to be done with reimbursement.
Right.
Okay, so you already said that it was not sustainable and not a paid for program, and the other programs are not able to sustain themselves. And you refer to the NRB program, and I'm going to look that up if there's anything available online on that or published. Okay, there's one more thing. I don't know if you talked about it. The community paramedic piece is kind of normalized with an actual license. And there are other people that are working with the industry and getting a reimbursement on those visits. So this is something to do with the regulation and how you get paid. So
No, our this would probably be how somebody else might get paid.
okay, so
Our
you are not under that model.
Yeah, our contract does our priority health contract does not mention community paramedics at all. So we're
Okay.
not required to use them. Yeah, we could use whatever resources we wanted.
It is interesting because I was looking for community paramedics on the cms.gov page, and it does not list Tandem 60, so but it lists Life EMS as a community paramedic.
Yes, the reason for that is if in order to be technically a community paramedic, you have to work for an ambulance agency.
Okay.
So the ambulance agency holds, the special study at the state of Michigan. It's been people at the state have commented to me before how funny it is that we've got probably the biggest community paramedic program in Michigan being run by not an ambulance agency. I guess
Okay.
that's very, very rare.
Well, that's unique, right? I mean, we can like sort of add that to the list. So I have been reading and hearing about this ET3 program. I don't know if you're aware of this. Do we have
Very, very
time?
well.
Are we running out of time for the meeting, or do we have a few minutes?
No,
I
no,
can
I'm
wrap
good.
up pretty quick.
Sorry, my wife was calling me.
No, that's okay. I understand because I think we set up this meeting for maybe half an hour, and I want to respect that. I'm just going to really quickly wrap this up. So the ET3 that has happened in the last 5 years or 3 years,
Probably 3 years. Yeah.
is that affect your model at all? Because it seems like it doesn't, right?
So yeah, everybody had these great ideas about ET3. It's been subsequently shuttered. It does not exist any longer.
Yeah.
But everybody had a great idea with this ET3 thing, but the way they built it and regulated it, nobody was really successful at running it. So of course, subsequently it got shut down.
Yeah,
But yeah, everybody that
I
I've
saw the
talked to,
website said it was shut down for lack of participation.
yeah, yeah. Well, everybody who ran it was like, "This is terrible. This doesn't work." I mean, you had to do things like you had to screen patients with a nurse and for insurance payers at the time the 911 call is coming in. So it was really hard to execute on.
Okay. So basically, what I'm hearing is that are you saying it's because the paramedics didn't have the training to deliver on ET3, or they did not have that tie up with a healthcare management team?
Yeah. So the only people that were covered by ET3 were Medicare, straight Medicare members, not Medicare Advantage members. So if you think about a 911 system, you don't even evaluate a patient's insurance until well after the call has been initiated and executed on. So these ambulance agencies had to try to figure out, okay, is this person that I'm talking to on the phone, are they straight Medicare? Do they even know what their health insurance is? And then they deploy a resource and find out they sent the wrong resource because they didn't have the correct information at the time of call. And it's just a mess the way it was structured.
Yeah. And another thing I kind of noticed that we didn't talk about before, and maybe this is a new part of your model, is that when 911 gets a call from you, they already know that they are a Tandem member.
Yeah.
This was already always there in the program?
No, we probably built that as time's gone on.
So that also helps, right? Because then they know that they have the option to triage and not necessarily transport.
Right. And so from an EMS side, EMS historically has no information. They don't have a database that they can look patients up in. So they don't have any information aside from what the person they're talking to is telling them. So when we can add all of the history, all the medications, all of the different things that have been done to that EMS person's kind of toolkit, they're much more equipped to better handle the patient.
Okay. So again, another point, like, I mean, going along, about that uniqueness around, I think this is something that having all that patient history even before the EMS person arrives, that also makes it unique, right? Okay, so I'm going to write this all up and send it back to you so
Okay.
you can check and add anything that you missed. Actually, for now, this is all I have. If you feel that I have missed anything, you can please feel free to add. And otherwise, I will follow up a little bit with you because we talked about some things we need to follow up on.
Yeah, and if you need clarity at any point while you're writing through this stuff, just shoot me an email. Either we can set up a quick call, or I can get you an answer by email.
Okay, perfect.
Okay.
That's it for me. Yeah.
All right. Well, thanks, Phil.
Yep, you're very welcome. It was good to see you both.
I'll see you soon.
Yeah, thank you, Phil.
Right.
Thank you for taking the time, and hopefully we're going to get something on paper pretty soon.
Great. That sounds good. I'm excited to read it.
All right.
All right. Bye now.
Bye-bye.